Thank you. And I would like to start by thanking the DDA for organizing this series of webinars regarding diabetes and cancer. I have really enjoyed all of the talks and the discussions afterwards. Today, I will be talking about the Colectomy study and the published study, which inspired us to perform the Colectomy study. And the title of the Colectomy study is Colonic Resection for Cancer as Diabetogenic Risk Factor. But I will start by giving you some facts about colon cancer, but be aware as one of them is false. So you see if you can guess which, and I will reveal later in the presentation which one is false. Okay, number one, colon cancer is increasing worldwide. I think Tina's talk helped a bit on guessing which one is false here. And number two, third most common colon cancer in the world is colon cancer, and the global incidence is 1.8 million cases in 2020. Number three, there's a 5-year survival rate in colon cancer ranging between 70% and 90%, and this is due to early detection and better treatments. That this survival rate has really improved. Number four, treatment of early stage non-metastatic colon cancer consists primarily of radiation. Number five, colon cancer survivors have an increased risk of developing type 2 diabetes. As mentioned in previous talks and also by Tina, the interrelation between colon cancer and type 2 diabetes has been recognized for some time now, and surprisingly limited information exists on the complex interaction between these two major pathologies. Co-prevalence of the diseases has traditionally largely been contributed to shared underlying risk factors like smoking, obesity, and low-grade inflammation. And also some work has provided evidence to the carcinogenic effects of poor glycemic control as a key contributor to an elevated risk of developing cancer, colon cancer in diabetic patients. In contrast, however, very limited information exists on the possible bidirectional relationship that cancer and its treatment drives the metabolic dysfunction, leading to a higher risk of developing diabetes in cancer survivors and colon cancer survivors, and especially how colon cancer treatment affects glucose homeostasis is what we are interested in our study. So the aim of my talk today will be to introduce you to how anti-cancer treatment of colon cancer affects or may affect glucose homeostasis in humans, and to introduce you to the Colectomy study that we are currently running. First, I would like to introduce myself. My name is Louise Lang Lehrskov, and I'm an MD and a PhD and a DDA-funded postdoc affiliated to the Center for Physical Activity Research at Rigshospitalet. I have started specialist training in oncology, doing part-time research, part-time clinical duties. And I was lucky to do my PhD within inflammation, metabolism, and glucose homeostasis in the lab of Professor Bente Klarlund Petersen. It's a very inspiring supervisor. And then I have these three guys keeping me busy when I'm not working. And some of the most exciting work I was involved in during my PhD led to this paper in a series of studies which showed that the cytokine interleukin-6 delay gastric emptying rate in humans with direct effect on glycemic control. So all of this work in glucose homeostasis may explain why on Earth a future oncologist is interested in diabetes. And when I started working with cancer patients, I was surprised that there are currently no specific guidelines or recommendations for diabetes screening among cancer survivors, even though we know that cancer survivors are more likely to develop diabetes. So I think there is a need for research within this area in order to identify which cancer patients are more susceptible to develop subsequent diabetes, so we can start screening of these patients. Now I'd like to introduce you to a study performed by my present supervisor, Jesper Frank Christensen. He performed this study with some co-workers at CFAS at Rigshospitalet. And this study was called the IWalk study, and 39 patients with colorectal cancer, non-metastatic, which is it was an early stage cancer. And they have completed the primary treatment. They were enrolled in this study. Yeah, so 39 patients with early stage colorectal cancer. And the primary treatment of colon cancer is not radiation. So there you have your false statement from the beginning of my talk. The primary treatment of non-metastatic early stage colon cancer is surgery, where you remove the part of the colon where the tumor is located, and sometimes adjuvant chemotherapy afterwards. These patients were randomized into two groups, an intervention group and an IWalk group. The IWalk group performed home-based interval walking for 150 minutes per week for 12 weeks. The control group was the usual care group. The patients came in for 2 study visits, one at baseline and one after 12 weeks. And among other things, glucose homeostasis were assessed using an OGTT. Moreover, body composition was used was assessed with a Dexa Scan. As expected, interval walking improved postprandial glycemic control, as we have seen in other studies. The upper panels show plasma glucose levels. Panel A show data from the control group, whereas panel B show data from the IWalk group. You can see the improved postprandial glucose. And panels C and D show the delta values. So interval walking improved glycemic control in these patients. The lower panels show postprandial insulin secretion, which was reduced after 12 weeks of interval walking. However, the surprisingly and unexpected finding in this study was an increased fat mass in the control group after 12 weeks, which was primarily driven by an increased amount of visceral fat, here stated as the android fat mass. And we know that increased amounts of visceral fat is correlated to insulin resistance and development of type 2 diabetes. So based on these data, we started speculating whether the anti-cancer treatment of these colon cancer patients per se has a detrimental effect on metabolism. Almost simultaneously as this IWalk study was published, and this paper based on a nationwide registry was published. This epidemiological study revealed that the surgical procedure per se may play a role in development of diabetes afterwards. They found that patients undergoing left-sided colectomy, which means removal of the left part of the colon, for example, as part of treatment of colon cancer, subsequently had an increased risk of developing diabetes. And they compared these patients to patients who had resections of the right side of the colon and a lot of other different kinds of operations. On the right side, you can see the hazard ratio of type 2 diabetes after colectomy, which means removal of part of the colon. And I've highlighted the left-sided resections. And as you can see, patients who underwent the left-sided resections had an increased diabetes risk. And this is, here you can see an illustration showing the gut. And as you can see, the colon form an arch, which encircles the small intestine. And the colon begins at the ascending colon, then comes the transverse colon, the descending colon, and finally the sigmoid colon. And thus the left side of the colon is also the distal part of the colon. And this illustration reveals what kind of colon resections are classified as left-sided resections. So this study indicated that if patients have a tumor located in the left side of the colon and therefore are treated with a left-sided colon resection, they are more likely to develop diabetes at a later time point. We were excited when we saw this and started collaborating with one of the authors, Professor Torkild E. Sørensen, and we joined forces and started discussing whether there is a causal effect of left-sided colon resection on the risk of developing type 2 diabetes, and what the biological mechanisms behind this association could be. because in general, the role of the colon in regulation of glucose homeostasis seems to be complex and not very well understood. One possible mechanism that we came up with was that left-sided colon resection may affect gut hormone secretion. It's well known that the gastrointestinal tract is the largest endocrine organ in the body, and along the entire tract, hormones important for regulation of glucose homeostasis are secreted, also appetite-regulating hormones. And from L cells in the distal part of the intestine, the hormones GLP-1 and PYY are secreted, and they are known to inhibit appetite, stimulate insulin secretion, delay gastric emptying, inhibit glucagon secretion, so they really improve glucose homeostasis. And the density of these L cells, the GLP-1 and PYY producing cells, increase from the proximal to the distal part of the intestine. Thus, more L cells are found in the distal part of the colon, which is also the left side of the colon, as I told you earlier. Therefore, we speculate whether the increased risk of developing type 2 diabetes when we remove the left side of the colon could be explained by removal of a large number of these L cells, leading to a reduced secretion of these glucose regulating hormones, of glucose. These hormones are very important for glucose homeostasis. Another possible mechanism could be a change in the microbiome of the colon. It has been shown that patients with type 2 diabetes have an altered fecal microbiome, and like the L cells, the bacterial colonization increases from the proximal to the distal part of the colon. So the bacterial colonization is also more pronounced in the left distal part of the colon. So another speculation is whether removal of the distal part of the colon, again the left part of the colon, crucially affects the gut microbiota, leading to a more diabetogenic microbiotic profile. Personally, I don't have experience with microbiome research, but luckily one of the leading experts in the world within this field, Professor Torben Hansen, is part of our research project as well. As already mentioned, early stage non-metastatic colon cancer is treated with surgery, sometimes in combination with adjuvant chemotherapy. The adjuvant chemotherapy is given in order to reduce the risk of disease recurrence, and that's even though the tumor has already been removed by surgery. And most often, the adjuvant treatment is 5-flu or CL5-FU. And in a study by Feng et al. From 2013, it was shown that treatment with this 5-FU induced diabetes in colon cancer survivors. Other studies haven't been that convincing, but we have to consider whether adjuvant chemotherapy play a role in the increased risk of developing diabetes that we see in colon cancer survivors. So based on what I just told you, we designed the Colectomy study, and the overall hypothesis is that the left-sided resection of the colon leads to a changed phenotype, increasing risk of diabetes later in life, and that adjuvant chemotherapy may play a role. The primary hypothesis is that resection of the left side of the colon leads to impaired glucose tolerance when measured with an OGTT, the 2-hour blood glucose, and that's driven by changes in postprandial secretion of gut hormones from the left part of the colon. And this is an illustration of the study design where 60 patients with non-metastatic colon cancer will be included. Half of the patients have a tumor in the right side of the colon and undergoes right-sided resection. They are our controls. Half of the patients have a tumor in the left side of the colon and undergoes left-sided resection. And moreover, half of the patients are planned to receive adjuvant chemotherapy. The study does have a 2x2 factual design in order to examine the individual effects of both left-sided colon resection versus the right-sided resection and adjuvant chemotherapy versus no chemotherapy, respectively. Patients will come in for 3 study visits. Visit 1 will be a baseline before the surgery, anti-cancer surgery. Visit 2 is planned 3 to 4 weeks after the surgery before they start chemotherapy. And if they start chemotherapy, and the last visit is visit 3, which is performed after 1 year. Good. On the 3 study days, we will assess the following. We will perform a Dexa scan in the morning in order to assess body composition. Then they will have blood samples taken in order to assess fasting blood glucose, HbA1c, inflammatory markers, bile acids, metabolomics, proteomics, etc. And then we will perform the 3-hour oral glucose tolerance test and measure postprandial glucose homeostasis, insulin secretion, insulin sensitivity, gastric emptying, gut hormone responses, of course. And then they will have a lipitor meal test, and we'll perform or do a VAS investigation in order to assess appetite and satiety. And they will have to hand in a fecal sample on all the study days as well. So we'll assess changes in all of these markers. With this study, we see the perspectives perspectives of the Colectomy study is to confirm or reject whether there's increased risk of type 2 diabetes after the left-sided colon resection plus minus adjuvant chemotherapy, and to maybe indicate a need for follow-up assessment of glucose homeostasis in some of these colon cancer survivors. And as the role of the colon is in regulation of glucose homeostasis is not well understood, maybe we will get some knowledge in how the colon is affecting glucose homeostasis. So I've shown you how treatment of colon cancer may affect glycemic control. And I've introduced you to the Colectomy study, which we're currently running. I don't have any data to show you yet, but maybe next time, I hope. At the moment, we're recruiting from 3 centers in Denmark, from Hvidovre, Herlev, and North Zealand's hospital. And this is an overview of all the people involved in the study. And the members of the steering group are highlighted in bold. And thank you, and I will be happy to take questions.
Thank you so much, Louise, for this really interesting talk. So if anybody has any questions, they can raise their hand or they can write it in the chat. And I can see that Tine has a question.
Yeah, I was just wondering whether you have, when you include the patient, have considered to take out a biopsy from the tumor as well, just to hide it and freeze it, because maybe it could be relevant at a certain point to look into that could give some information, maybe in an earlier stage, who will develop the diabetes. Maybe you could tell it by which kind of tumor do they have. It's just a very complicated study that you're doing, so I was just thinking of it could be nice to have the samples.
Yeah,
and it's easy to get them
normally
from the beginning.
That's a good idea. I know we have the pathology department to measure the length of the colon that they are resecting or they're removing, so we have an idea of whether the length of the tumor means anything. But it's a good idea to keep a sample, maybe. Yeah, thank you.
Yeah, it was just a consideration. I didn't have a specific aim, but maybe actually you could tell from already when you have the tumor, which maybe that could be an indication of which kind of patient. I know that's a little bit off the line what you are looking into, because you think it's removing the cells by the surgery, but it was just a consideration.
Yeah. There seems to be a difference between the right and the left-sided, the left and the right-sided tumor. When you look at it in a microscope. It has been shown before that they have another profile. So I don't know if it would add anything, but I will definitely take it into consideration.
Yeah, it was just, it's now you have to consider, you have to collect the samples. Otherwise you will end up only have paraffin embedded. So it was just.
Okay. Do you have more questions, Tina, for Louise?
No.
Okay, so then we have one question in the chat, and it is from Kenneth. He writes, interesting design. I was wondering whether the 4 groups will be matched for body composition, physical activity, nutritional intake, and will known type 2 diabetic patients already be excluded beforehand?
Yes, thank you. We measure body composition, of course, body composition, physical activity, and we will measure what their diet before on all the study days, the day before the study day. But we won't match them. It is pretty difficult to include patients in this study. So we will look at it afterwards, whether there is a difference between the group, whether the baseline values are different, but we're not able at this point to match them. But there should be no difference when we look at this cohort. Overall, they should be matched. So, but it is a design with a small sample size, so we could end up with a difference in important factors as you are describing body composition and things like that. And the second thing, of course, we will exclude patients with the type 2 diabetes. And if they develop diabetes during the study, we will have them stop the medication for 1 day, typically, of course, depending on which anti-diabetic medications they are taking, but they will have to pause their medication before the study day. But they are excluded at baseline. It's a pretty tough design. I think we have to screen 100 patients to include one or something. It is pretty difficult. Due to we are very effective when we diagnose patients. They are typically operated within a week or something. So we have a very short window of performing the first visit.
Well, if it was easy, then everyone would do it, right?
Exactly.
So I also have a question.
Yes.
So I guess your hypothesis is that the colon resection is causing the metabolic abnormalities. So my question is, if there are evidence in the literature or from cell cultures to show that cancerous colon cells have altered secretion of, for example, GLP-1 or PYY, or if the cancer per se could alter for example, also the gut microbiome, but also the secretion of these gut hormones.
Yes, so if I understand your question correctly, you ask whether they're in left-sided tumors, whether you could show that they affect GLP-1 secretion compared to right-sided tumors or something like that.
Yeah, for example, yeah, exactly, yeah. Well, maybe not compared to right-sided tumors, but maybe if the cancerous colon has a different secretion profile compared to non-cancerous left-side colon, I guess then. I haven't been, I'm not aware of studies showing that. I've of course looked in the literature, but I haven't found anything that indicates that. But it is interesting whether the cancer could be able to change the secretion. Okay. Are there any more questions for Louise? No, but I think we'll just say thank you then, Louise, for a very nice talk.